And we're in an interesting place in the management of HER2-positive breast cancer where we're talking about more efficacious therapies, what some might consider to be an escalation of therapy, if you will. I actually consider it to be just a replacement with more efficacious therapies. But we're also talking about de-escalation, right? We've got trials that are looking at maintenance setting, trials that are looking at stopping HER2-directed therapy. In my mind, I tie this all together by saying we really want to use our most effective therapies up front to optimize disease control. And then when we can talk about what we do subsequently, and I think you highlighted that nicely in terms of tumor response. Dr. Macklin, in terms of the efficacy with regard to T-DXd and pertuzumab, what are your thoughts about using this approach up front? Dr. Jhaveri mentioned the validation of T-DXd as monotherapy in the second-line setting and beyond, and the efficacy of T-DXd monotherapy in that setting. Should we be using T-DXd and pertuzumab up front, or should we save it for later? I certainly have some comments on that, but I would like to hear your thoughts.
Yeah, I mean, I think this is the question we're all asking, right? I think the bigger question is, does everybody need to be using T-DXd up front? And it's really tricky because we know that HER2-positive breast cancer is not a monolith. There